your Post-Bacc.
Sit there with the other troublemakers. All right, let's get started, please. Let's get started. Thank you. Thank you. Thank you for coming. Remember, we're going to endeavor to start on time and finish on time. So let's get rolling. Anybody have a question before we go? How's it going? Fall chemistry fun? Fall biology, everything fun? Good. I'm glad. All right, we're going to start bringing questions to class. Starting next week, I'll pick on two of you, but this week I decided to start low and go slow. So Jeremy's up, go for it. What's on your mind?
Sure. I guess with the ability of the government to negotiate with Medicare drug costs, I guess my question is, how do you see this positively impact on patients? And do you think that this is that there may be some consequences of this that we're not aware of yet?
All right, are you all aware of the background here? Up until very recently, Medicare was prohibited by law from negotiating for drug prices with drug companies, even though they are one of the largest, if not the largest purchaser of drugs. There was a law inserted during one of the past congressional sessions, which made it illegal for them to do that. So this would be the equivalent of Walmart not being able to negotiate the price of pickles. It's completely anti-capitalist and anti-competitive. That has been reversed, at least temporarily. Now it could come back in again, depending on what happens in Washington. So now Medicare, who is the big gorilla on the block, can squeeze the drug companies for bargains on medication. Potential upside, obviously, is the saving of a great deal of money for Medicare and for patients, because patients do pay a piece of their drug cost with Medicare. That's also relatively new. Medicare historically had Part A and Part B, which Part A being hospital care and Part B being physician care. Sometime around the Affordable Care Act, maybe actually a bit earlier, they added Part D, which is drug coverage. Historically, Medicare did not cover any outpatient prescriptions. Covered all your drugs in the hospital to the degree that your hospital stay was covered, but you could go to a pharmacy and get a huge bill. Historically, this wasn't a problem because there were no expensive drugs. Medicare, remember 1964, there were only a couple of dozen drugs on the market and none of them cost that much. Inflation and drug development caught up with that, and now there are enormously expensive outpatient drugs. So Medicare finally came around to that, and now there's a complex Part D. It's called the donut. You pay something and then you stop paying something and then you start again. It's not an easy thing to understand. I haven't looked into it deep enough to understand it. So there is now an outpatient drug benefit for Medicare. The fact that Medicare can now negotiate for prices will help that, but also help drive down the cost of hospital care, because Medicare obviously is going to pay for your drugs in the hospital, but that has to do with the hospital bargain for the drugs, not necessarily Medicare. But at the same time, you now have a giant purchaser who can bring pressure to bear on drug companies. Those would be the positive effects. The negative effects, if you listen to the drug companies, will be we have to make so much money on the drugs we have because we have to put all the extra profit we make back into research and development to make wonderful new drugs to cure everything that's out there. There is some truth to that. Although if you look at the large pharmaceutical companies, what they do with their profits, a huge amount of it goes to paying themselves. They pay their stockholders, they pay their executives, they pay their lawyers, they pay everybody involved in this. And at the same time, recently, a number of the large companies have really gotten out of research and development themselves. What they do is set money aside, wait for a small company to develop a good drug and then just buy it. So they do need money to either seed smaller companies or do their own research and development. However, nowhere close to 100% of their profit goes to that. An awful lot of it goes as profit to reward the people that work for them and own their stocks. So they are going to claim that this is going to hamper the development of drugs, and eventually cures will sit languishing somewhere and we'll all die of something that could have been cured if we only gave them enough money. I'm not buying it 100%, but I think there is some legitimacy to it. Is that where you're going with this?
Yeah, that's what I wanted to know. And do you think, like, it sounds like they're gonna expand this over the next year to different drugs. Like, it seems like it's really nice that there's like a $35 a month cap on how much it costs for insulin. And I think that there's a $2,000 cap already in place for what their patients, it's like, I don't fully understand it either, but it sounds like a certain group of patients, if you qualify, like, you only spend, $2,000, I think, a year on medications, but even that is about $170.
Yeah, it's a lot for somebody on a limited income. Medicare Part A has a deductible, even the hospital portion of Medicare has a deductible. It's $1,500 or something. It's not that much. And the drug plan, again, there's a limit. You have to pay the first 2,000, then you don't. And then you might actually have to kick in again if you reach a higher limit. I honestly haven't looked into it that much, but it's certainly better than it was. If any of you travel abroad and have to go to the hospital or a pharmacy, you'll find patented brand name American drugs for sale at a fraction of what they cost here. The identical drug. I'm not even talking about generics. I'm talking about brand name drugs, and they just don't cost, they cost hardly anything. And that is because all the foreign governments have the ability to bargain with the drug companies. And they say, fine, you just can't sell your stuff here. If you don't give us the price we won't let you sell it here. We've never done that. And so the idea being that the drug companies need all this extra money to help us has some logic, but they're going to help themselves first because that's the way profit-making enterprises work. Nobody here had a career in the drug business, did they?
I worked for Pfizer for a year.
Did you really? What'd you do for them?
I was their first industrial hygienist, so I protected the workers from the workplace hazards.
Where?
In Groton.
In Connecticut at the big Pfizer, right
Yeah.
near the submarine base.
Yes, I learned
Interesting.
a lot.
I'll bet.
Yeah.
I invest in a drug discovery company.
You do, or
I well, still have some small interest, I guess. But,
what are they discovering?
well, they built a platform that was very accurate at predicting certain qualities for a certain part of the like preclinical trials. So they were licensing that to bigger drug companies to help them kind of like improve their pipelines, but they were building their own capacity as well.
The drug development business is really expensive. I mean, the FDA, in order to get a drug on the market, it has to be safe and effective. And there's a ton of steps hoops you have to jump through to get it done. So I have some sympathy with the drug industry. It is expensive to bring a drug to market, but at the same time, they make exorbitant profit sometimes. And again, the question again comes down to whether we're talking about a commodity or a social good. Should we regulate their profits and force them to turn them back into research and development or rebate customers, or do we let them just go unfettered? And heretofore, they've gone unfettered. Once you get a drug to market, the marginal cost of making another capsule is like infinitesimally small. The chemistry is all there, and they just run them and make tons and tons of this stuff for almost nothing. But they will tell you, and there's some truth to it, they have to recruit all the drugs that failed. All the ones they tried to bring to market and failed, they've got to make money on. And they have a short patent period as well. You're not far enough into organic chemistry to do enantiomers yet, are you? No? Well, I'll save my enantiomer drug story till later then. Or it'll mean more to you when we talk about enantiomers. So perfect kind of a question. Really, that's just fine. And I'll assign two of you. We'll go backwards through the alphabet and just bring whatever interests you to class, and we'll go with it. So last week, we didn't quite get through the first lecture, which is fine. There's no particular schedule for this class. We do what we do. We sort of finished on the match fairly quickly. And so we'll go back through this. Do any of you have any lingering thoughts or questions about this thing that you're going to end up dropping yourselves into? Did I tell you a couple of years ago that somebody thought this would clearly be over? So I gave this lecture to the class and somebody raised their hand and said, "Oh, this is so stupid. We clearly won't be doing this by the time we get on this." Yeah, you will. And it's going to be worse. I mean, the one piece of good news is that there are fewer applicants to medical schools and more positions in medical school. So it's actually now easier to get in numerically than it was a couple of years ago, but the match has not kept pace. And there will be a continuing deficit of positions because the positions are controlled by the right hand and the medical school enrollment is controlled by the left hand, and the right and the left hand do not communicate necessarily. Most residency positions are funded by Medicare. Medicare actually, you're allowed, if you run a residency program at a hospital, to charge Medicare more for the same procedure if you don't. So there's a Medicare, it's basically a surtax. So Martha Jefferson Hospital across town, which has no residents, might charge Medicare $1,500 for a gallbladder surgery. We get to charge them $1,650. I'm making these numbers up. And that extra money supposedly goes to support the residency program. In addition to Medicare, sometimes outright funding positions. Hospitals fund positions, commercial entities are now funding positions, and anybody can fund one as long as it's approved. It costs about $125,000 to support a resident for a year. The bulk of that going to the resident's salary, but then the rest goes to all the infrastructure that's necessary. So again, it ain't over till it's over, and it's not over. We now are in a position of relicensing and recertification in every specialty. So you will be taking tests for the rest of your life, roughly every 10 years. The good news is the recertification exams are typically easier than the certification exam. And you just have to stay up to date and go and take some kind of refresher course is usually a good idea. And some of the times I went to the refresher courses for the board exam in emergency medicine, they literally stood up there and said, "This will be on the exam." And it was. I was stunned, but they really had that much information about what was going to be tested. It's an interesting situation they're in because the boards don't want to flunk too many people, but they also don't want to pass everybody. So the pass rate on the certification exams is in the low 90s. And they really are not that hard if you pay attention. I don't know, George, has that been your experience? That was mine.
But the data is the same. UVA and internal medicine now has what's called longitudinal knowledge assessment. So you can do 30 questions a quarter of the year, all the time at home on your computer without the data open, and never take the giant 10-year exam.
So it's an open book, real open book. Interesting. Do all the boards do that?
I don't know.
In family medicine, the tests went from 7 years to 10, as long as you did 50 medical hours of education per year, which could be teaching medical students, but also you had to go to a few lecture halls and listen. And that did make it easier. And some of the testing you had to do was like clinical. So you would follow longitudinally patients in your practice, let's say for insulin-dependent diabetes. And then you would hope that you could improve their care by taking the tests every quarter. And then at the end of the year, you would, so anyway, it was more involved than just taking an occasional test, but it was better.
But what's interesting is it varies by specialty. There's no cross specialty agreement in this, but at any rate, you're going to be taking tests and proving that you know something from this point on. Most licensing, again, licensing is a state function. Most of that requires that you do some continuing education, certain 60 hours, I think it is now for Virginia every year. They just went to the honor system, which I think is fascinating. You used to have to submit all your stuff, in order to renew your license. I just renewed mine and they said, have you done this? I said, yes. And they basically said, every now and then, we're going to make you prove this. And so you get these certificates for continuing education. I don't know of anybody that's been called on it. The other absurd thing that happened, so I finished medical school in on internal medicine residency in the dark ages. I was certified in internal medicine in 1983. There was no recertification exam. And so we were issued a permanent lifetime certification in internal medicine. About 8 or 10 years later, they decided that they really needed to test people's knowledge and bring in this recertification exam. And they made everybody take it except the people that had already been granted lifetime. So the people that needed it the most, arguably. So mine is still clean. I've never taken a certification exam in internal medicine again, which is absurd. But that's the way that it went. There is a continuing thing that probably I needed to do if I was still practicing. But mine does not expire. And I expect they might have done that with some of the other boards, but that's going to go beyond. You have already taken a lot of standardized tests. You're going to take a bunch more. And some of them are really hard. In my life, I think the hardest one I took was the original internal medicine certification exam. There were no computers. We all sat in a big auditorium. Do you remember this, Greg? Yeah, sure. And it was actually a clinical thing on it where there was like a scratch and sniff thing that you erased. So they would give you a couple of choices and then you would erase the answer that you thought it was. And then that would take, it was care of a patient. It would take you down this algorithmic thing. They don't do that anymore, do they?
No, it's pretty cool though. I like it.
Yeah, I thought it was really interesting, but one of the cases was a patient with herpes simplex encephalitis. And the diagnosis was extremely clear clinically. And you had the choice at the branch point. Herpes simplex encephalitis is a horrible disease. It's a brain infection, but the classic symptom is olfactory hallucinations. People think they smell something in the room. The 2 patients I've seen with it have come to the ER saying, I smelled something all the time and it's not there. One guy smelled oranges. And another guy, I can't remember what the other guy did. But anyway, so fever, altered mental status, and olfactory hallucinations. And then you had a choice of the treatment, which I think at the time was an antiviral agent, probably one of the real primitive ones, or a brain biopsy. And if you did the brain biopsy, it was wrong because you didn't need it, because you knew exactly what was wrong with this patient. And so around the room, seriously, I'm sitting there and people that are ahead of me going, because you erase brain biopsy, it said something like patient dies, or patient has horrible outcome, or you've just wasted $10,000 and put this in. But I literally remember this. It was, oh my God, what happened. It was really very funny. Wouldn't get away with that. The way you guys take the things with your headphones and everything. That was a very funny story at the time, but not for the people that took it. All right, so, and then now even you have to be credentialed to be paid. So you can't submit a bill to Blue Cross unless they know who you are. And you have to be on their certified panel of people who deserve payment. So insurance companies will ask you to make sure that you've passed all these certification requirements as well. And that can be an extremely lengthy process to get approved for payment for insurance companies. So here's what you get to pick from along the way. And this is really only the sum of the primary boards. Each primary board has subspecialty boards. And some of the subspecialty boards go to more than one primary board. So critical care you can actually get to through internal medicine, anesthesiology, and surgery, at least, and probably emergency medicine. Palliative care you can get through OBGYN, family medicine, emergency medicine, internal medicine, a whole bunch of different anesthesia, many different specialties. All I can tell you about this is it will continue to change. When I finished medical school, 2 of the 3 specialties I practiced didn't exist in an organized fashion. So there will be new things. I can't tell you what they're going to be, but there will be new things. for you to get involved with, but there are lots and lots of choices, which is somewhat the problem as a medical student. How do you possibly pick among all of these things with really a very limited exposure to them? So we're going to talk about money because it's important to a lot of the things we're going to talk about. So, you know, this is the answer to that quiz I gave you that no one knew the answers to. Keep in your mind, you know, $4 to $5 trillion, and this information is always a couple of years old. This is like 2022 data. It takes a long time to sort out this big piece of money. $13,400 per person, way more than any other country, way more than even our closest rival, if you will. It's interesting. I took a medical economics course in college, and at the time, 20% of the healthcare budget was spent on physicians and clinicians. That was more than 50 years ago, and that percentage really hasn't changed. It's still right around 20%. So although physicians, the gross amount of money physicians get is much higher because the denominator is much higher, the fraction of medical care which goes to physician compensation has remained the same for more than 50 years, which is just an interesting piece of this. Used to put just physicians, now you have to say clinicians as well, because some of the people we've talked about, nurse practitioners and PAs and doctors of nursing practice, can now independently bill for care, and some of them are paid outside of the physician compensation that happens. Prescription drugs, 14%. That's climbing, as you can imagine, based on the fact that we have some of these incredibly expensive and sometimes quite effective drugs. We did see a little bit of growth flattening. If you look at the increase in expenditure every year per capita, it flattened some during COVID. Mostly because we stopped taking care of people unless they were really sick. And so the demand during COVID dropped way off. We've still never gone backwards. We've never had a year where medical care cost less per capita than it did the year before. Yes?
Where would other hospital staff, like nurses, CNAs, fall under? Would that be hospital care?
Yeah, hospital care, the hospital bill that you get typically covers room and board, the so-called hotel services, the bed and the room and the heat and the lights and the food. Nursing care, the nurses typically work for the hospital. All of the lab and x-ray charges, irrespective of the cost for a physician to interpret them. So the hospital generally owns the MRI and the x-ray, and they employ the x-ray techs. They also employ typically the respiratory therapist, the occupational therapist, the physical therapist, the nurse's aides, the janitors, the front desk people, the parking lot attendant, everybody. So that's all just lumped in as hospital care. So it's a large bill behind which there are a lot of professional services, but they're lumped together. So the hospital is going to bill for their employees. Physician billing is separate, even for physicians who are employed by the hospital, because you submit an entirely different charge. It may be to the same company, but the physician charge is entirely different. The hospital generally will bill you by the day for room and board, and then they will also itemize the x-rays, itemize the labs, itemize everything else. Physician charges are either billed by procedure. If you replace somebody's knee, you send in a code for a knee replacement, and that's all they'll pay you for. Even if it requires examining them 5 times a day, you still just get a lump sum for knee replacement. There are also other codes based on what you've done and how much time you've spent with a patient that translate into a number, which translate into a negotiated reimbursement. It's an extremely unnecessarily complex process. If you've ever been in the hospital and had them print your bill out, it can be hundreds of pages long. So who do we spend the money on? Like most things that we're going to talk about in terms of money and resources, this is extremely irregular. Most of the people don't cost very much at all. So the cost of care, the expenditures on care is skewed heavily toward a small number of people. Most of us aren't that sick. And even when most of us get sick, we're not that expensively sick. So you have a small number of people who are enormously expensive to care for. And these are all estimates. In fact, remember the 20/80 rule. If somebody ever asks you a question and you don't know the answer, and it's like a percentage question, like what percentage of people with gallbladder disease present with epigastric pain? If you think it's not too many, guess 20. If you think it's a lot, guess 80, and you'll be close most of the time. So the 20/80 rule says that 20% of the patients consume 80% of the resources. And at the real outer edge of this, 1% consume 25%. These are people that are very sick and chronically ill. The chronically ill are the expensive people to care for. Acutely, terribly ill people might die, and that's actually fairly inexpensive on a daily basis to care for somebody who comes into the hospital and 3 days later is dead. They might run up a bill of a couple $100,000, but then it's done. Whereas if you're a dialysis patient, you're going to cost the federal government about $600 a week at least for as long as you live. And that tends to mount up significantly. So we really have, again, a skew, a maldistribution, because disease is not distributed evenly across the population. Young people are inexpensive, middle-aged and older healthy people are fairly inexpensive. They have heart disease, cancer, psychiatric disease, and respiratory disease. Some of them have all of these. Many people actually have all of these things, and it's really quite difficult to take care of them. And again, 80%, which is most of the rest of us in the room here, consume only about 20% of the resources. So like any insurance plan, healthy people pay in and don't get back anywhere close to what their insurance costs them. Like your car insurance, you pay for the accident you don't have. And at the end of the year, if you haven't had an accident, you can't get your money back because someone else has had an accident and you've paid to repair their car. Health insurance works the same way. And most healthy people pay way into a plan and don't get it back. And I think they have to, otherwise actuarially the insurance wouldn't work. Yes.
Since it looks like the majority of the finances are spent on like a specific section for like cardiovascular disease, cancer, and such, do you think there's going to be a shift towards more preventative care or like proactive treatment in the future to address these before they get serious enough to cost so much money?
There should be. And if we had a single payer that was responsible for your care longitudinally, that would make sense, right? If I own you from birth to death, it would behoove me when you're 25 and have bad diabetes to take extremely good care of you, because I'm going to save my money if you don't have to be dialyzed or don't need a kidney transplant. However, what happens here? You're covered by Aetna when you're 25. If I'm running Aetna, and I don't blame, I'm only picking Aetna because it's the first one that came to mind. I can know actuarially by the time that you are 50, you will not be covered by Aetna. Your generation is going to change jobs at least 7 times. You're going to change insurers more than 7 times. So there's really no profit. There's no point in me saving money by taking good care of you now to prevent me from spending money on you later, because it's not going to be my money. The other worst thing that happens, but which I think is the moral hazard, if there's any economic here, is everybody gets to be dumped on Medicare when they're 65. So if I can get you to 65 without you costing me any money, I'm done. I'm done. And so there are perverse incentives. I'm not saying people do this, but they probably do. I have no proof that they do this, but I don't know why they wouldn't. There are really perverse incentives to not manage long-term disease effectively if you're only looking at profit and outcome down the line. Question?
I know some commercial health insurance companies will offer health promotion incentives. Like they'll send you a $25 gift card if you send them proof that you got a pap smear this year.
We get that here. I get $100 back from my health insurance if I have a physical.
So what would be the incentive for if the insurance companies aren't really wanting, they're wanting you to take care of yourself?
They're wanting you to take care of yourself better. They're looking at short-term gains, but still not necessarily long-term gains.
Okay.
And in various, like if I was an insurance company for a municipality, like the police and the firemen, I would be on them every day because I probably am gonna own them for the rest of their life. Those are career jobs now. And also remember now that fairly recently, the idea that you have to continue to cover pre-existing conditions became the law. So now insurance companies really can't play the way they used to and just drop everything that was wrong with you if you came into the plan. But we still have the cushion of Medicare. You still get people to limp into 65, you can drop them completely.
I guess I just thought it was more of like a moral, like, oh, it's like, oh, we want our people to be healthy. But now I'm realizing it's really just an economic decision.
I hope you're right. I really do.
It's telling me like this is the right thing to do.
I'm afraid that you aren't, but I hope that you are. And I know there are good people here, really good people on both sides, right? But you know, that the economics of it really don't make that kind of sense, yeah.
I have noticed recently, before I retired, that I was getting notes from a health insurance company saying, don't you want to put this patient on Lipitor?
Oh, interesting.
Because they have high cholesterol. And, you know, part of me took it as a nuisance, you know, wasting my time. I'm a smart doctor, I don't need to know this. But part of it, I was saying, okay, this is good.
Yeah, so
Yes.
they're now worried about longitudinal care.
Somehow, I don't
Um,
know how, but they are.
well, I think the Affordable Care Act made, if, you know, either they're gonna own you in 25 years, which is less likely, or they're gonna own somebody else from another plan who dumped into their pool who wasn't on Lipitor. So maybe the whole industry is coming around. But that's kind of an interesting idea, isn't it? That a health insurer would tell you how to take care of your patients.
Yeah.
That's a very interesting.
Oh, it's not a small number for just limited cholesterol testing. You will get from all of the major insurers now on a quarterly basis. You have the following women under the age of so-and-so haven't had a pap smear in the last 3 years. You have this many diabetics who be on a hemoglobin A1C on record the last 6 months. You know,
And what's the penalty
none, they're just making sure you're aware so far.
so far?
Some will dock how much they give you.
Yeah,
a year.
in theory, they would.
Quality incentive.
Yeah,
They hold, yeah.
they have a quality metric. You're not a very good doctor. We're paying you 80% of what we pay the guys that are good.
Exactly.
Or eventually they'll say, we're not gonna pay you anymore. You're not a good enough doctor.
It wouldn't get renewed.
Yeah, you wouldn't get renewed. Your privileges wouldn't get renewed. So there's a lot of snooping, maybe motivated appropriately. Who knows what the motivation is? But this is new. I mean, prior to the Affordable Care Act, there was nothing like this at all. So again, not to beat a dead horse, but the issue with all this money is that the health metrics in the United States are really pretty bad. And in fact, in certain population subgroups, they're as bad as they are in the third world. And the problem is not that we can't deliver excellent care, we can. The problem is we don't deliver it across the board on an equal basis to everybody. We will talk a lot about health disparities and who's on the outside of the door as we move through the semester here. So where does the money come from? It comes from the government. Don't let anybody convince you that the answer to the healthcare funding crisis is to get the government out of it. You'll hear that from some person in the campaign this fall. If the government gets out of healthcare, the healthcare system will collapse. It's at least half of the support and a great deal of more than half of the support for larger entities like hospitals and health systems. So the horse is way out of the barn now in terms of going back to the private sector. 1/5 of the total healthcare budget is just Medicare. And almost another 1/5 is Medicaid. So these are large programs that are really contributing a great deal to the support and, you know, for the care of people. Just about a third, and this is a pretty fixed number, about a third of all the money that's spent is run through private insurers. And again, that's over $1 trillion. What's interesting, of course, is that that's about also 70% of the population. So one of the funny math things that you'll hear, which is mathematically correct, is that here's the problem. The government is really inefficient. The government is taking care of about 100 million people, and it's costing the government $20,000 a piece to take care of those people. The private insurers are taking care of 200 million people, and it only costs them $5,000 a person to care for them. So what we need to do is, so the government's inefficient, the government can't do anything. All we have to do is put everybody on private insurance, and the cost of care would come down. The math works. The expenditure per person for private health insurance is less than half of what the government pays for Medicare and Medicaid patients. So why don't we just do that? Why don't we just dump these programs and put all these people on private health insurance because they're so efficient? It's only going to cost them $5,000 a person. What's the flaw in that logic? Go.
The healthcare companies can choose who they serve, so they can,
Well, but also who do they serve?
they serve like a
They serve young, healthy, employed, well people, so they cherry pick, right? They will not take care of a diabetic who's blind and has no legs and is in a nursing home. They will not sell that person insurance, or if they do, the insurance would be so expensive that they wouldn't buy it. So you have again a skew. The skew in the government programs is toward the sick and the poor and the elderly, who are the three groups of people that are really expensive to care for. The skew in the private world is toward the young and the healthy and the employed and the well-to-do, who are really cheap to take care of. Yes.
Why isn't it that the government just, why is it that they pay so much more? I don't know how to word this. How is it that we can get so much money from the government in terms of paying for stuff like this? I don't know if you know where
I'm not understanding what you're saying.
Okay. Places know that they can charge the government more, and if I'm wrong on this, then that might be where my misunderstanding is.
No, they can't charge the government more.
Okay,
You must charge everyone the same. That's the law.
that's where it was, okay.
What you get back is entirely all over the map. So the cost for an appendectomy might be $15,000. You have to send everybody, whoever gets your appendectomy, they got to get a bill for $50,000. The government, Medicare, can look at it and say, 6,500 is what you get. Medicaid can look at it and say, 4,200 is what you get. Aetna can look at it and say, I'll give you 11,000. Another commercial payer might give you even more, but these are all negotiated, except the federal prices, they're all negotiated. So every 2 or 3 years, every practice and every hospital has to sit down with their insurers and argue over what percentage of the charge they're going to be paid. Nobody pays charges anymore. Workers' comp used to. A long time ago, workers' comp actually paid charges, which was a gold mine. But no more. So the payer mix of your practice is enormously important, because if you have a lot of Medicaid and Medicare mostly these days, you're not going to be making much money. If you don't have much Medicaid, and in fact you have a bunch of commercial payers, you're going to be making a whole lot more money. Let me have a question here. So
what's the issue with writing policy where the private company, forcing the private companies to insure people that they don't want to insure? and then reducing public funds.
You know the answer to that. Oh, the government doesn't get to enter, it doesn't tell Ford which cars to sell.
Right.
These are private profit-making listed on the stock exchange commercial entities.
So they have nothing to hold against them.
Not so far. I mean, you could legislate anything you wanted, but the legislation, it's a powerful lobby.
Yeah.
It's a very powerful lobby.
So then what type of system would lead to, you said preventative care is most profitable when there's more vertical integration, essentially? So
Yeah.
what sort of, because I think of like late stage capital is usually resulting in like a few big companies.
We already have that in the insurance
Right.
industry.
So what leads to the like positive positive vertical integration where like you are taking care of people over a longer amount of time versus, I guess nothing, right? Because no matter what, when they reach a certain age, they're off.
Well, in our system, yeah.
Yeah.
But socialization would fix this completely. If everyone was on Medicare from birth,
Oh, I see.
that
Okay.
would fix this entirely.
I see.
Because Medicare would then have an incentive to spend their money early rather than spend more money later.
Okay.
In theory,
Mhm.
that would happen. And in the Western European countries, all of whom have socialized medicine of one kind or another, you find a huge emphasis on primary care and preventive care,
Mhm.
and very little emphasis on end of life, expensive stuff that doesn't work. Yeah, question here, so.
I was gonna comment that it's also guaranteed, like Medicare at 65, you will be on Medicare. And so that person who performs that appendectomy knows that you will get $6,500 from that.
Yeah, Medicare is a good payer, they're just not terribly generous.
Right.
It isn't difficult to bill Medicare and they pay. But again, they don't pay as much and you can't bargain with them. It's not like we can sit and bargain with Medicare every 2 years. And so what you find is a cross subsidization here, the commercial payers cross subsidize the losses from Medicare, Medicaid and uninsured people, yeah.
This is a question about like physician, I guess, going kind of go back a little bit to physician billing for like all these different procedures. When you say physicians bill separately from hospital care, does that mean? I'm reading this book right now, and the doctor for the first years of his career, he has a salary, and then from there, he has to do his like own billing.
Sometimes.
So is that like entirely separate from like what we've talked about with hospitals, like encouraging doctors to do more like?
No, because typically, if a doctor does a procedure in a hospital, there is a coincident hospital bill for that procedure, which is usually larger than the physician fee. So if I come to a hospital as a joint replacement surgeon and I start doing knee replacements on people who can pay, I'm going to bill, I don't even know, 5,000-6,000. You guys even know?
Probably.
How much JB bills for? I have no idea, but let's say it's $5,000 or $6,000. My personal work, me going in there and sawing all this thing and making it fit and sewing it up and it's not infected, I'm going to bill Medicare $5,000. The hospital will bill for the operating room, the recovery room, the nurses, the respiratory therapist, the drugs. Now, the anesthesiologist is going to send a separate bill as well. So not only am I scratching the back of the hospital, I'm scratching the back of my colleagues in anesthesia. If the patient gets a fever, then the ID doctors see him. More and more these days, Dr. Hoke and his people take care of all these people, except when they're in the operating room. So there is a lot of ancillary increase in everybody being able to charge more when you do hospital-based procedures.
Okay.
And typically the physician fee is the smallest of those, but it's still not inconsiderable.
Yeah.
Which means that if you're running a hospital, you want to find a whole bunch of doctors that will come and do big surgical cases on people that pay. Because that's where you make your money. And what you don't want is a whole bunch of doctors who admit patients with pneumonia and have no insurance. That's just a loser. across the board. So you find a lot of active and passive skewing of payer mix by hospitals. Go ahead.
Couple things. So Centera is a nonprofit, quote unquote, hospital system that bought the hospital I used to be on the staff of on Jefferson. My close friend said that Centera loses money on everything. They make their money on their health insurance plan, Optima. But I just asked my new best friend, ChatGPT, what does it cost the government to administer Medicare?
I can tell you it's less than 5%.
Yes, 2 to 3% and 8 to 20 or 12 to 20% private.
So
So,
why does it stop at 20? You know?
well, now it's not.
It's
Now
the law.
it's mandated.
Yeah, it's the law.
Before that, it was
Yeah.
whatever you want.
Yeah, so health insurance companies are legally allowed to make a 20% profit, but no more. Yeah, no, the whole argument that Medicare is inefficient is silly. So 95 cents of every dollar that goes into Medicare comes out as care. 80 cents of every dollar that goes into Aetna comes out as care. And they use the rest to buy airplanes and pay each other. I mean, it's a beautiful piece of capital. Up at the business school, they love it. I think it's probably unfair that there's a 20% cap. So, I mean, so right away, if we wiped out the commercial insurance agencies and enrolled everyone in Medicare, we would drop 17 of the 20% overhead that commercial agencies make right now. That's billions of dollars. So we should just do it. It would work extremely well, but I don't see that we're going to. So out of pocket, 471 billion, and a lot more as time goes on. What you're finding with health insurance is they would rather not overtly raise their rates, the commercial carriers. So what they do is cut the benefits. So what you find out if you pay close attention to your insurance when it renews is your copay for an ER visit where you're not admitted used to be $50, now it's $200. Your copay for pharmacy used to be $5, now it's $40. And they will either stop covering certain procedures, or again, it's always in the fine print. But more and more of the cost of care is being pushed very slowly and gradually onto consumers. Copays is another example of this going on. Again, the federal government isn't the only government that pays for healthcare. Cities and counties and states pay for healthcare also. So there's a big piece of that. It's also tax money that goes in depending on where you live. Some of the largest hospitals in the country are county hospitals. Cook County Hospital in Chicago, LA County, Grady Hospital in Atlanta. Those are county hospitals supported by county taxpayers. UVA is, at least on paper, a state hospital. 11% do we get, something like that? And the rest of it we're supposed to make up on our own. I'm actually surprised Martha Judson doesn't make any money because their payer mix is unbelievable.
It's true, but
Huge.
like my friend Bill Maloney, who left my practice to go to Centera because he could make more, said that they told him already that they lose just on his salary, not counting the overhead to pay for the internal medicine clinic. So it is surprising.
Because they're supposed to be fairly shrewd business people. I mean, at one point, and this was several years ago, I got to look at their books. Their Medicaid inpatient percent was 3%. The 3% of their inpatients were Medicaid. Yeah.
There's not a zero missing.
Yeah, 0.3.
But, and their previous CEO was making 12 million a year. Now he's retired and it's on the board of trustees to decide this. The new one makes 2 or 3 million.
I do that job.
Yeah, I do it.
Seriously. Do it for an hour.
Do it for half. Yeah, they had 3%. And why is that? The town is full of Medicaid patients.
Yeah.
And they get sick. Where are they?
And it's aging.
Where are they? Yeah, they're across the
Right
street.
here.
They're at the university. So there's a huge, I can't believe they don't make money. They're in a perfect situation. They don't have to take care of anybody. They don't want to. They can just send them all across town.
Yeah, well, that's true. Yeah,
That's
that's
remarkable. The other hidden thing in here, which is really interesting, and and confusing, and I only just started to make sense of it. And I hope I can explain it. If you run a company and you offer health insurance to your employees, which large companies have to do, you pay a share of that. You pay sometimes 60, 70, 80% of that. That is tax exempt. That's not counted as income for the company. It's a business expense. If in fact that was taxable as revenue, it's a $300 billion subsidy. So basically the fact that the cost of health insurance by an employer is tax exempt is a $300 billion gift to private industry, because the rest of the money they make is taxable. But they're allowed to say that they're putting this back in the business, so it's an interesting piece of economics that a lot of people do not recognize. So the government's in this deep and will stay deep. So we'll go back to if you can remember, this is the first slide. We're talking about the American healthcare system. I would argue that what we would like to have is number 5, harmonious, orderly interaction. What we really have is number 1. And we need to work, we should work on moving from number 1 into number 5, because we have an extremely balkanized, in many cases, profit-driven system, which really doesn't add up to the best way to care for everyone in the country. So not healthy, not caring, and not a system is really, so healthcare system, really, none of those is true. The system isn't healthy, it doesn't care, and it is not a system at all. So as we go forward today, and for the rest of the year, and for the rest of your career, shouldn't there be a better way to do this? I mean, is this really the right way to try to care for this many people with this many complexities going on? And is healthcare a commodity or a social good? The rest of the Western world and a lot of the developed Eastern world has come down on the side of saying that healthcare is a social good, that it's to some degree a right. And you, with a social good, you take from people that have and you move to people that have not. And we do that for lots of things in our culture. We just don't do it for healthcare across the board. We do it for police protection. We do it for fire protection. We do it for public schools. We do it for, to some degree, higher education. The military, right? You get military protection whether you pay for it or not. It's a right of citizenship. So it's a social good. Commodities are priced, and people can be priced out of the market. And commodities have profits and prices and costs, and people cannot afford things, and that's what happens to healthcare. And also this idea that there's quite a difference between healthcare and medical care. What we have in the United States is a reactive system. We wait for people to get sick and then throw everything at them to make them feel better. What you find around the world and what you find in longitudinal cost sharing system is a lot of emphasis on prevention so that you don't have to throw a ton of money at illness when the illness occurs. I told you I went to public health school. One of the first lectures we got was from somebody who wanted to know the difference, who asked us if we knew the difference between medical care and public health care. And the metaphor was a river with a bend in it. And, well, that's terrible. There are a whole bunch of people here on the shore watching the current come by, and the current is carrying drowning people. And the doctors are jumping in the river and pulling the drowning people out and doing CPR on them and saving their lives. And the drowning people keep coming, and the doctors keep pulling them out and trying to save their lives. The public health person walks over this way to find out why the people are falling in the river in the first place when they can't swim. And so that's a pretty good analogy for the difference between medical care and healthcare. So let's take a break there and come back in a couple of minutes and we'll keep going. So just announcements, on the eighteenth, is that right, Austin? We're gonna start with your presentations. You have to pair up and give a presentation to the class. And there'll be a sign-up sheet for that. It'll go for both semesters, so there are only gonna be about 15 of them. But in the past, I know we've used people's chemistry lab partners. How are you faring this year?
They were given,
I'm sorry?
they were given to me. So
Okay.
I decided.
So you have a partner. I guess you can trade if everybody agrees. And you're just supposed to bring something that interests you. It can be something that you worked on in the past. It could be something that will come out of the class that interests you, or something that's totally unrelated to what we've talked about, but still related to the topic. Try to limit it to 10 minutes and then 5 minutes for questions. And if you want to run some topics by one of us, please do. But really, anything that interests you is what is interesting to me. We can get into politics if you want to. You can look at the platforms of the people running for office. We can talk about financing. We can talk about healthcare reform options. We can talk about really anything you want. But something that interests you and excites you is what we're looking for. And we'll start that in a couple of weeks. Don't stress out about it, please. It should be interesting and fun. You're not going to get a grade on it except that you did it. And life imitates art. I got to show you something here. I got a text when we were at break here. I'm supposed to make a decision about how much the hospital is going to make for this patient. Lady admitted through the ER with dyspnea on exertion, meaning that she's winded and has to rest after walking 10 feet. She's at home on supplemental oxygen. She has coronary artery disease, chronic lung disease, lung cancer following a surgery and radiation, a kidney stone with open drainage out of her abdomen into a bag, diabetes, hypertension, heart failure, and she had a heart attack in June. This is one patient who Dr. Hoke is going to take care of, right? Right?
Are you gonna make her inpatient?
Almost certainly you're going to get it.
Yeah.
Now, this is the kind of person you get,
Yeah,
right? This is,
I probably know this.
yeah. So again, I mean, what could illustrate this better? There's a few people out there with multiple things wrong with them. And in 1965, this lady would be dead. And that's where the problem with Medicare is. They looked at patients like this and said, we'll never have to pay for them. They'll be dead. But she's alive and reasonably well. And we will continue to try to care for her, but it's not going to be cheap. Yeah, I think she deserves it. She's a high risk patient for sure.
Hopefully she'll get a nurse when she's discharged. You're gonna see her, what, every 3 days?
It would be great, yeah. No, she'll end up actually going to a nursing home.
Yeah.
Almost certainly. She will be discharged using her Medicare benefit for 25 days at a rehab center. We have no nursing homes anymore. We just have a rehab center. But she'll run up a pretty big bill, tens of thousands of dollars already, probably, that she's run up. Another thing that came up at the break is My Own Country. Have all of you read it? Everybody finished it? Did you like it? Yeah. Good. Well, we'll take some time to talk about it. I do want to get through a couple of the introductory lectures first, because they actually have some relation to the conundrum that Dr. Bernice found himself in. I still think it's a wonderful book, in spite of the fact that it's set now 40, 50 years ago. All right, so more money talk, and we'll just move through a little bit of history. So how did we get here? I mean, I think we've talked a little bit about where we are. I want to talk a little bit more now about this sort of how this happened. We won't go back much farther than the early 20th century, because really in the 19th century, we were dealing mostly with sort of caring without healing. There was the physician's role really was kind of to watch diseases progress and kind of define what was going to happen, but there really wasn't much intervention that worked very well. Some surgical procedures worked. You know, there wasn't even anesthesia that worked up until the early part of the 20th century. You look at the Matthew Brady photographs of the surgeons in the Civil War, you know, whiskey and biting bullets, and then they're using carpentry tools to saw off limbs. no anesthesia, no blood supply, no antibiotics, nothing. So a lot of caring, a lot of concern, and really not much in the way of credentialing. You could sort of call yourself a doctor and you were a doctor. The early surgeons were barbers because they had a basin to catch the blood in and something sharp to cut with. There were really no hospitals. The early hospitals were asylums where they locked up lunatics. And the payment system was the same as any other payment system, which is that the customers paid the vendor directly. And whether you owned a livery stable or a car dealership or you were a doctor, you sent your patients a bill and they paid you or they didn't. But it was a direct transaction between the two of you. Instead of giving you money, they might have given you vegetables or mowed your lawn. But it was a direct payment system really up until the early part of the 20th century. Into the 1920s, we get into finally the standardization of this, the Flexner report. Go ahead.
My grandfather was telling me about how he was working at this clinic in Memphis, Tennessee, and it was kind of one of those like pay out however much you can, and one of the guys paid him a mattress.
Yeah, a new one, I hope.
Yeah.
So, I mean, that's kind of the way it worked. You took care of your neighbors and they may give you a ham in the spring or mow your lawn or take care of your children or something like that. But it was really the Wild West, literally, in terms of training and licensing. And then you finally get into this standardization of training and the licensing and ultimately the professionalization of practice. When something becomes a profession, a couple of things happen. One is restriction of access. Not everybody can be that thing. So there's some hurdle you have to jump, and the hurdle is usually controlled by the people that are already there. So the lawyers decide who can be a lawyer, the doctors decide who can be a doctor, the engineers decide who's going to be a doctor. And that limits access. It should raise quality and standardize what it means to call yourself a lawyer or an engineer. But it also gives those people somewhat of a monopoly, which means that now they can start charging more for their services because their services are discrete and in demand, and not everybody can do it. Health insurance, in many people's minds, is traced back to Dallas in 1929. So this is the Depression. Stock market crash was in 29. And the Dallas Public School Service, even then, the teachers were worried that the hospital cost a lot of money and they weren't paid very well. It is true today. Hospitals cost a lot of money and public school teachers aren't paid very well. And Baylor, the big hospital in town, had cash flow problems because nobody had any money because it was the Depression. So somebody came up with this idea that the teachers would each pay 50 cents a month to the hospital. And in exchange for that, they got 21 days in the hospital free. So this is really the beginning of rudimentary insurance. Specifically interesting, though, this more represents the Kaiser situation we have now than most health insurance, in that the premiums, the insurance payments were going to the provider directly. They were not going to a third party who then paid the provider. So this is really a model that, in my opinion, should have persisted, but for some reason fell by the wayside into the triangulation model we have now. Rolling into the 1930s and 40s, we get quite increase in the actual scientific basis of practice. Germ theory becomes accepted, the idea that maybe you ought to wash your hands in between operating on people, or maybe even wear gloves that are sterile. Antibiotics become available and effective. Sulfa and penicillin turn up. Anesthesia that people actually recover from and don't remember being cut on happens, and so sophisticated surgery where the people actually survive becomes possible. This gives physicians a lot more autonomy. Now, in addition to belonging to a guild, a group of privileged people, now they actually can help people. And so their services become far more in demand and actually far more expensive, because why wouldn't you? If you can actually save somebody's life, it seems like you ought to be paid more than if you simply sit and watch them die. The other big development then comes in World War II. World War II in this country, in spite of the fact the war really never touched the continental US except maybe the Alaskan Aleutians, there was a giant mobilization of the workforce. 20 million people were in uniform during World War II, and the population was only 4 or 5 times that. So what you had was an enormous scarcity of labor, huge labor shortage at home, and at the same time, a booming economy. Because not only did the soldiers and sailors and Air Force people go overseas, with them went airplanes and bullets and bombs and ships and uniforms and food and shoes, gasoline, anything you can imagine to fight a war had to be manufactured. So there's a manufacturing boom underwritten by the government, and at the same time, a labor shortage. So if you're running an airplane factory, you've got to find a mechanic to help build the engines to stick in your P-40s. And there aren't too many of those guys around. And in classic economic theory, if 2 people are competing for the same laborer, 2 companies are competing for the same laborer, what happens to wages? They go up, right? Because guy says Grumman's willing to pay me $10 an hour. Boeing is only going to pay me $8 an hour. Unless you match that, I'm going to work for Grumman. And if I'm valuable, then people are going to pay me more. But what happened during the war as a policy decision is the Roosevelt administration put wage and price controls in. So they forbade inflation of wages. And that made it very difficult for employers to bargain for labor. The loophole in this, and I'm not sure anybody knows whether it was delivered or not, is the wage controls did not cover benefits. So in fact, if I'm forced to pay all my engineers $10 an hour, I might then say, but I'll give you lunch. I'll give you a parking space. I'll give you a uniform. I'll give you 3 weeks off instead of 2 weeks off. So I'm going to compensate you non-monetarily to keep you working for me, because I can't give you any more money. It's against the law for me to give you any more money. Somebody, I don't know who, decided it would be a good idea to make health insurance a benefit. So in addition to uniform and lunch free and maybe Friday afternoons off, now my company says, if you stick with me, we'll buy you a health insurance policy. And there was so much money in the economy and healthcare cost so little that this was not a bad deal for anybody. It was a tiny additional cost to the company that was making bombs and bullets and whatever else needed to be made. So this gets sort of enshrined in American industry, that one of the benefits of being an employee is health insurance. Your employer is going to give you health insurance, and that's part of the deal. So we come out of World War II into a giant economic expansion. And the same companies that had been making war material begin to make refrigerators and cars and tires and air conditioners and all the other things that we associate with modern life. So there's a giant manufacturing expansion. And at the same time, a skilled labor shortage, and people are sucked into these jobs, most of which are for large companies, many of which are unionized. And what comes with them is health insurance, just because that's what we do now. Physicians now, instead of relying on their neighbor to mow their lawn or give them a ham, now actually have a pretty good source of income. So if you come into my office now and show me that you work for Ford, I can now send Ford's insurer a bill for your care, and they're going to pay me. So now I have a guaranteed income flow. Whereas before it was a little bit of a crapshoot. If you had money, I got it, but sometimes I got my lawn mowed. Now I get $40. And all I have to do is write down that I saw you, write down that you work for Ford, and send the bill in, and somebody pays me. So the physician income goes up. And because in our culture, we equate status with income, physicians become more prestigious. They become honored members of the community instead of old hacks like they were in the 19th century. Nobody watches Gunsmoke anymore, do they? Is Gunsmoke even on reruns?
Every nursing home plays guns. You do, black and white.
The doctor in Gunsmoke is great. He's a drunk, right? And mostly he's in Miss Kitty's saloon, and which is where they find him when somebody gets shot or falls off his horse. But he's a great manifestation of the 19th century doctor. So because people now have insurance, they're getting care that they didn't get before. And the cost of care is going up because they can. So the hospitals are doing great too. The hospitals used to have to count on barter and however else they could get cash, or many of them just philanthropic events. But now patients have money, and the patients go in the hospital and get care, and the care is paid for. So everybody's in good shape here. The patients are getting what they want, the doctors are getting paid, and the hospitals are getting paid. And the economy is booming, and the cost of this care for employed people and their families is pretty much borne by the employers. But that's okay because they're doing extremely well. Things really take off in the 1960s. So the decade turns over, Kennedy is elected in 1960 and assassinated shortly thereafter, and Lyndon Johnson becomes president. It's hard probably for those of you who aren't students of history to understand this, but at the time, a prevailing American vision and Johnson's vision was that government is a force of good. Government is not evil. Government actually exists to do good things for the population. And Johnson had a mandate when he came into office and looked around, and one of the things his program was called the Great Society. One of the things that he wanted to fix was the disparity in the health insurance system. When you have a health insurance system that covers employed workers and their families, who is left out?
Unemployed people and single people.
Not necessarily single people, unemployed single people, but employed single people get insurance. Who else? Unemployed people and old people, right? Who are unemployed, okay? So you have poor people, people that don't have a job, and you have old people. And those are the two groups that are left out of the commercial insurance business the way it exists. Johnson, to his credit, or maybe in retrospect, made a mistake. And instead of making the commercial insurance people pick up the poor and the elderly, he said, this is what the government's going to do. The government is going to step in where capitalism fails and provide a safety net that the private sector won't do. So out of this comes Medicaid and Medicare. And if you go back, interestingly enough, these programs were really opposed by organized medicine. Physicians wanted nothing to do with this. They wanted no interference, if you will, of the government in their practice. And the spokesperson actually for the AMA who made commercials objecting to this was an out-of-work actor named Ronald Reagan. Yeah. And he came back and got his revenge. Later on in life. So Medicare and Medicaid are well-meaning plans designed to shore up the inequity in the population. Yes?
When looking at this timeline, would it have been, like, with the civil rights movement as well, would these things and like policies being put in place have been different for like Black individuals? Or were like when healthcare plans started rolling out, was it kind of similar for everyone? How did that work?
Well, the healthcare plans, the commercial plans didn't discriminate based on race. They discriminated based on employment and affordability,
Yeah.
which turns out to discriminate based
Yeah.
on race, but it's not, it's perhaps accidental or deliberate, but that's what happens.
Okay,
Whenever you start pushing something toward the educated and well-to-do segments of the population, you're going to leave behind Black and brown people. That's the story of the United States.
Yeah.
So in essence, this becomes fairer because Medicare and Medicaid Medicare is an age-based entitlement and Medicaid is an income-based entitlement. And they don't, it doesn't matter what your racial background is, or that you just get it or you don't. So in spite of the protestations of the doctors, these things pass, and it turns out to be a bonanza. Because now, in addition to this group of people that have commercial insurance and will pay you, now everybody else now has insurance and they'll pay you too. So everybody, in theory, has a means of paying. And there's no more people that aren't covered except the occasional person who falls through the cracks here. Unfortunately, these are indemnity plans, meaning that there is no budget in them. And they just pay the bills as they come in. And they were originally charge-based. So if you charge Medicare $500, you got $500, or 80% of $500. And if you charge them $1,000, you got 80% of $1,000. So it worked really quite well on that sector of the population. Then you have still an economic expansion, lots of unionized jobs, lots of people working for large corporations who are profitable. And this idea that health insurance is going to be sacrosanct in an employment contract is still prevailing. So you have huge corporations who are employing large numbers of people and they're buying health insurance for them. And the health insurance cost is inching up bit by bit by bit, because now we're into the 1960s and you can do things like dialyze people, open heart surgery becomes possible, ICU care becomes possible. So things become more complex, more effective, but also more expensive. And then obviously you've got huge accomplishments in things like cancer care and non-invasive surgery, imaging, CT scanning, MRI scanning, things like that start to become more prevalent. And again, healthcare is more effective in most cases, but also costlier. The physician-hospital relationship turns into a really interesting thing here, because they really just scratch each other's backs. We talked about inpatient procedures. If I am a physician, a surgeon that does a lot of procedures, a hospital that has me on their staff is going to make a bunch of money off of my patients, as long as I admit the right patients. And they're going to discourage me from admitting people that they lose money on. But if I've got a steady stream of people with insurance and a steady stream of people who need a procedure, I'm going to be a very valuable member of that medical staff. Also, if I'm not a proceduralist, I'm going to be a valuable member of the medical staff if I keep a bunch of patients in the hospital all the time. Because hospitals at the time were paid like hotels, they were paid by the day. And if a patient stayed 3 days, they got 3 times X, but if they stayed 30 days, they got 30 times X. And keeping people in the hospital and doing stuff to them became a way to make money. When I was a medical student here, there was no medical school in Roanoke, and we used to go to Roanoke for 6 or 8 weeks at a time. And I went down there and did general surgery, I think, and cardiology. And I worked with a private cardiology at the Roanoke Hospital, who was a wonderful physician and a good man. But he had an office and he had patients in the hospital. And he would come in the morning and meet me, and we would see all of his patients. We'd round on all of his patients, just him and me. And then he would leave to go to the office, and he'd give me a piece of paper and he'd say, keep an eye out for these people. I'm admitting 3 people today. Mrs. Jones is coming in, needs a pacemaker. Mr. Johnson's not doing well with heart failure. His wife's going to bring him in. And Mrs. Swenson has complete heart block and a bad valve, and she might even need surgery. So keep an eye out for them. The page operator will call you when they come in. I want you to go look at them and make sure they're okay. If they look bad, call me, and I'll be back. And he would come in the afternoon, and if he told me he was going to admit 3 people got admitted, and sometimes more, but because he would see 6 people in the office. But he was always straightforward about who he was going to get. A friend of mine is working for a pulmonary doctor, and we are comparing notes. And the pulmonary doctor does the same thing with one difference. At the end of their rounds in the morning, he says to my friend, I'm admitting 8 people today. And he did. every day. If he said he admitted 8, he admitted 8. If he said he admitted 6, he admitted 6. My friend said to me, so you know who these people are? And I said, yeah, he tells me. And he said, I never know their names. I never know what's wrong with them. All I know is the number. And he's never wrong. Sometimes he's wrong up, but he's never wrong down. Neither of us could figure this out. So at the very end of the rotation down there, my friend screws up his courage and said, what's the deal? How do you always know how many people you're going to admit? And he said, oh, it's simple. I need 30 people in here all the time. I have figured out that I can make $100,000 a year if I have 30 people in the hospital all the time, just on my hospital practice. And everything above that is gravy. So if we round and we have 22 people, I'm giving you 8. If we round and have 25, I'm giving you 5. And this is how this worked. And the hospital loved him because he had 30 people in all the time, and they got to bill for 30 days for all of his patients. And it worked really beautifully for everybody. It's not ethical or moral or even legal, but it worked. Go ahead.
How do hospitals balance that with lack of bed space and kind of their reputation about getting people in and out?
There was no such thing of lack of bed space in the 1980s.
Okay.
Hospitals were huge, 1,000, 1,500 beds.
But now, what would you say?
Well, we'll get to that.
Okay.
They're very different now than they used to be. Go ahead, Greg.
Well, you and I will have competing stories here. So 3 of us reopened a little hospital in North Carolina. And the CEO of the little 16-bed hospital was a banker in Indianapolis. He was not a hospital administrator. Jim would call me on Tuesday morning and say, Greg, our last patient is being discharged. Can you find somebody today? No problem. Ouch.
Minneapolis VA, when I was a resident there were no attendings in the ER, and hardly any attendings anywhere, actually. And the VA at the time had what they nicknamed sweeps week, like supermarket sweeps or TV station sweeps. And they took a snapshot of the census, like February 15th, and then funded you the coming year based on your census during sweeps week. So the chief of medicine called us up and said, go down there, boys, and let them all in, right? Fill up the place tomorrow. And we could. I mean, people like to be in the hospital. In those days, it was easy. And if somebody came all the way from Miles City, Montana with a tummy ache that had for a month, you just admitted them. And everybody, I mean, people understand funding mechanisms, right? They understand, and they're able to game almost any system that you have. So the trick in healthcare, if you're trying to get stuff done, is to figure out which rock to hide the money under, because we'll find it. And if you hide it under procedures, we'll do the procedures. If you hide it under preventive care, we'll do the preventive care. It's really, unfortunately, more financially driven than you might wish to think. So the 60s, 70s, 80s did great. There was no incentive to discharge anybody. People stayed 25, 30 days. People came in the hospital for workups. People brought in their silk pillowcases and their PJs, and I remember this. They had satin nightgowns and things, and there were a couple of doctors here that were famous for admitting these people for weeks and weeks at a time.
They would drop their mom off at Christmas time. Yeah. We're going out of town. Yeah. You take care of mom for a few days.
For a couple of days, yeah. And you know, someone who had a headache for a month got hospitalized. And they got a LP the first day and a neurology consult the second day, and somebody else saw them the third day, and then they got a head CT the fourth day. It's just, you know, very leisurely pace of things. And there was no such thing as a bed shortage. The hospitals were open and jammed full of people, but they had plenty of beds. Go ahead.
That's basically what I was gonna ask. Is that like also true with like Vietnam veterans in the VA? Like they didn't have any shortage of beds for them either.
The VA shrunk before the Vietnam War. And ironically, when I was at the Minneapolis VA, it was an old facility, and Congress appropriated, so this was in 1983, Congress appropriated money to build a big new VA in Minneapolis. And one of the ways they got the appropriation through was that the VA was never going to need another hospital because there wouldn't be any more wars. Didn't really work out that well. But the VA has had trouble keeping pace with the constant. So big bulge of World War II era vets. Most of them are dead. I took care of a lot of them in the 80s, but most of them, very few are alive anymore. Korean War, then a period of really no military conflict for quite some time. And then the Vietnam War and then the subsequent wars. The VA budget has gone up and up and up and up since then. So they have trouble like everybody does, staffing beds. It's nurses really that are causing the shortage in most places now, the nursing shortage. But also the fact that you don't make that much money. You now make money by churning as opposed to keeping people in for a long time. There was also, the federal government continued to be generous. There's something called the Hill-Burton Act, which allowed hospitals to borrow capital from the federal government to expand the size of their facility or to buy a CT scanner or something. And then they didn't have to pay it back if they could prove that they'd given away the equivalent amount of money in charity care. So again, this was a generous, community-minded thing. We'll give this to your hospital and you can have a brand new ICU, but at the same time, you need to be a little more generous taking care of people that can't pay you. And then we'll just forgive the loan. So the Hill-Burton Act worked to expand not only facilities, but also to buy expensive equipment. And once you buy an expensive piece of equipment, you have to use it. Otherwise, you start to lose money on it. So once you buy a CAT scanner or once you open an ICU, you're going to fill it with people that need those services. Otherwise, the economics don't work. I'm at the point where everything is tagged with a story. Martha Jefferson Hospital, the private hospital across town, used to be right downtown. It used to be right there by really a couple of blocks from downtown. It's now it's at the corner of Locust Avenue and High Street. And it was and is a very good hospital for what they do. But they took a bunch of Hill-Burton money. So given that, so they're what, maybe 3 miles from the university originally?
Probably, yeah.
Maybe 3 miles.
Maybe 2.
Yeah, you could ride your bike easily from the old Martha Jefferson to UVA. At the time, I'm running the ER in the old hospital here, and we're bursting at the seams. And the president of Martha Jefferson at the time is in the newspaper because the federal government is demanding their Hill-Burton money back because they loaned them a bunch of money and they have not provided the paperwork to justify not paying it back. And the guy is in the paper quoted as saying, "We really tried, but we couldn't find any poor people." They're right next to a subsidized housing project, right? All they had to do was open the door and they found, we had them all, is really what the group was. So you have this capital expansion, you have really, everybody's going great. And then of course, like all good things, it comes to an end. People got even greedier. And physicians looked at this 80-20 split and said, boy, for every $100 spent on healthcare, physicians only get 20%. Somebody else is getting 80%. The hospitals, the radiology suites, the procedure people, we need to get a piece of that because we're essential. We're the essential people here. Hospitals don't admit people, doctors do. So the doctors start to buy the lab so they can charge for the lab tests. They start to buy X-ray machines and do their own X-rays. They open up surgery centers and start charging not only the surgery fee, but the facility fee, which is usually bigger than the surgery fee. And they start to own nursing homes and start to use their own lab for labs on their patients, use their own surgery center for operating on people and put them in the nursing home that they own. And basically own this thing from beginning to end, which is extremely profitable. Insurers are still on this indemnity-based plan, which means if I'm running Ford Motor Company, I hire United Health to insure my people, and basically they just skim 15–20% off the money. If I send them $10 million a week, they take $1 million of that to run the program and send the other 9 million out, or take 2 million probably, and send the other 8 million out. So as long as money is coming through insurance from a corporation, the insurance company is doing well because they're just getting a flat percentage or a bigger percentage of a bigger and bigger and bigger stream of money. Doctors are doing great. Got 30 people in the hospital all the time. It takes me an hour to see them. I'm gonna make $100,000. Why wouldn't I? And patients are happy. What you learn about American culture is patients love to have stuff done with them and they love to be sick as long as they're not really sick. So they love to be in the hospital. They love to get tests. They love to get x-rays. They love to see specialists. They love to get second opinions. They just eat the stuff up as long as they don't pay for it. And in this market, there was no such thing as a copay. Everything was just covered. So the care appeared to be free to most patients who had commercial insurance. Same with Medicaid and Medicare. So it really was a perfect storm, which turned into a storm because eventually we have this giant swollen budget that somebody is paying for. So who finally decides this is not a good idea? First of all, the government, Medicaid and Medicare have ballooned. No one, the right-minded people that put these programs in had no idea how much they were going to cost. They tried and tried to get expert opinions about what was going to happen and what the budget was going to be, and they were off by orders of magnitude. The federal government, Medicare covers dialysis, and it covers dialysis for anybody. You don't even have to, you get to be an honorary Medicare patient if you need dialysis. Chronic dialysis, not acute dialysis. So there are 5-year-olds on Medicare because they have renal failure. I did a MPH project actually on dialysis and went and looked at the original congressional hearings, and it was really pretty fascinating how they got this through. Mostly appealing to the good-hearted sentiment of their colleagues, the Senate and the Congress, saying, we have a life-saving treatment here. And that is being denied to people because there aren't enough machines and there's not enough money to pay for the machines. And this is just wrong. This is against every American value. We should pay for this. And somebody, of course, raised their hand and said, how much will this cost? And they said, well, we've talked to all of the doctors out there who are experts in this, and it's going to cost no more than X. It turned out to cost 20X because the doctors way underestimated not only how many people were going to be dialyzed, but who was going to be dialyzed. At the time, dialysis machines were quite restricted. There were not very many. So this is a life-saving, life-altering, life-prolonging process, which is not available to everybody. So a hospital might have had 4 or 5 dialysis machines, which means they had, for the sake of argument, 11 slots a day. And you have to be dialyzed 3 times a week. So they had a number of people they could dialyze, and I'll pick a number, let's say 50. And once they hit 50, they couldn't dialyze anybody until somebody died. And how they decided to dialyze people in many circumstances is really pretty chilling if you read about it now. Hospitals had, they didn't call them this, but they basically had worthiness committees. And if your kidneys were failing, you petitioned to this committee to look over your portfolio and see if you deserve dialysis. And they tried their best. I mean, you have a demand bigger than a supply. And so they put a minister on it and some community people and a kidney doctor and some other doctors and a hospital administrator. And they sat, in this room and looked at applications and interviewed people and thumbs up and thumbs down over, and the people who got thumbs down died. One of the compelling arguments at the time was if you looked at who these dialysis committees approved for dialysis, it was overwhelmingly what? Married white men. The rationale being, and it was interesting, I mean, these are not awful people in most cases. They basically said, look, if a married white man dies, then his wife and all of his children become wards of the state and become an economic burden on us. Whereas if a single woman dies, she doesn't leave anything behind. And because of the nature of the economy, there were more white people employed than brown and black people. There were more white people employed in higher positions with worthy families. And so this turned out not deliberately, but the net effect of it was enormously discriminatory and very upsetting. So again, government is a force of good in this, and the Congress looked at this and said, we can't have this. This is just wrong. We're gonna let anybody who's here get dialyzed. Any citizen is gonna get dialyzed. And so they offered this out as a very generous benefit, which they thought wouldn't cost very much, and it has ended up being enormously expensive. So the government now is looking at this bill that they thought they'd never get, and it's huge and it's growing every year. The industries are finally balking. What used to cost them a few bucks a week to insure people is now costing them hundreds and thousands of dollars a year to insure people. They've got these union contracts, which are non-renewable for 5 years, and they're locked into paying these insurance benefits. The cost of the insurance keeps going up and up and up, and everybody's tired of this. The president of Chrysler famously testified before Congress and said, we're paying more for health insurance than we are for steel. We're basically an insurance company that happens to make cars. And this is just not right. We can't keep this up, particularly since now the Japanese and the Germans are flooding the US market with inexpensive cars. And one of the reasons why you can make cars cheaper in Japan is that Toyota doesn't have to pay for health insurance for their workers, because health insurance is a citizen's right in Japan. It comes through the tax system. So everybody pays. So Toyota doesn't pay any more than anybody else, and Toyota pays considerably less than Ford does for health insurance. So now we've got economic competitiveness being hampered, and at the same time, the government is balking because they're paying a ton of money that they were not prepared to pay for. So here comes Mr. Reagan back again with a vengeance. And very quickly, the worm turns politically in the country. The environment shifts completely. And instead of unemployed people being considered worthy of pity and help, a leg up, they're now lazy and undeserving welfare queens sitting on the back porch collecting a welfare check, spending all the money on cigarettes and alcohol, having 25 children. So the poor get demonized. And then it turns out that the elderly have gone from being the poorest demographic in the country to the wealthiest demographic in the country in 25 years. And part of that is because the principal cost in retirement used to be medical care. And now they don't pay for it anymore. So now they have condos in Florida and they're playing shuffleboard at the taxpayer's expense. So this becomes a compelling argument. And then they turn on the doctors and find, of course, that a bunch of us are crooked, and we're filling our own nursing homes with people who don't really need to be there. We're getting labs in our own lab that the patients don't need. We're billing Medicare, we're billing Medicaid, we're billing health insurance. So a host of regulation happens then in the early and late 1980s. Welfare reform, Medicare reform, Medicaid reform, fraud and abuse, the so-called Stark Acts, named after Congressman Stark, which really prohibit doctors now from owning and operating a facility that they continue to feed into to some degree. You can still own a service center and do your own surgery there, but there are more regulations than there used to be. What they did with Medicare and Medicaid is go from indemnity charge-based to flat rate reimbursement. And that totally changed the financial picture for hospitals. DRG, diagnosis related group, and rate regulation came in. So again, in the old days, like when I was down in Roanoke, you got paid by the day for every patient that was there. The doctor got paid and the hospital got paid. What Medicare did was flip over, and most insurance companies followed and started paying based on diagnosis. And they basically said, they have a giant chart somewhere which says 80-year-old lady, diabetes, pneumonia, fever, $15,000. And if you can take care of her for less than $15,000, you can keep the change. But if you take care of her for more than $15,000, you eat it. So all of a sudden, everything flips 180 degrees. Now it's profitable to get people out of the hospital quickly, as opposed to keeping them in there for a long time. It's profitable now to churn the beds and roll them over quickly, because once somebody stays past their DRG rate, they become a liability. So the whole economic picture for hospitals changes overnight with DRGs, and we're still in the DRG realm right now. And this has not reversed the Medicare cost expansion, but blunted it considerably. So Medicare basically now has a huge rate schedule, and the rate schedule is based on diagnosis. And there, of course, has spawned a whole industry to game this. So now we have people scrubbing through charts, trying to make sure that every possible legitimate diagnosis is listed on the patient's record, because each of them might add a tiny bit more to reimbursement. So there's a giant subculture industry of consultants and employees who now do nothing but try to make sure that charts are accurate. And obviously, typically a couple times a year, you'll find a scandal, and usually in a for-profit hospital network, where people have upcoded charts and basically lied on them to see if Medicare would pay them more. If you are in practice now in the hospital, you are barraged with phone calls and emails and texts about, couldn't you write down that this person has delirium? Couldn't you write down that this person has diabetes? Couldn't you write down that this person has an oxygen requirement? Because it won't change the way you care for them because you're already doing it, but the hospital will make more money if you accurately put this down. And there's pushback between the physicians and the chart people about what's legitimate to put. And a lot of ill will, honestly, that comes out with this. Dr. Hope can comment on this more than me. I've been out of this for 7 or 8 years, but it's really, it interferes with your ability to care for people when someone is constantly telling you, well, can't you write this? Can't you write this? Can't you write this? But it's the way of the world, and we figured out how to do our best to game this legitimately, of course, but that when there's always room for illegitimacy as well. So this takes us into the 90s. And again, everything's turned on its head. Instead of volume, now you're paid for efficiency, and you're paid for cost savings and reduction. So the people that run hospitals are coming to the doctor saying, you know, we only get $8,000 for pneumonia for your patients. Could you quit getting x-rays on them every day? Do you have to really get a pulmonary consult on everybody with pneumonia? Couldn't you use penicillin instead of a cephalosporin? Couldn't you reduce the cost of their admission so the profit margin is there? The other thing that happens is if you're not good at this, you begin to get in trouble with the hospital where you have privileges for the hospital that you work for. And if you continue to be an outlier, if everybody else's pneumonia patients go home in 4 days and yours go home in 8, eventually you're going to get a knock on your office door and somebody's going to say, what's the deal here? Do you not know how to take care of people with pneumonia? And what's the first thing you're going to say? Of
course I do.
Of course I do.
Patients are sick.
My patients are sicker, and your data must be wrong. I couldn't possibly be a bad doctor because you're obviously measuring the wrong thing. So there's a lot of back and forth and a lot of back and forth, but people lose their privileges. People are removed from hospital admission rights if they screw this up repeatedly. I saw it happen when I was in the private sector for a while, that if your patients are constantly outside the limit of what the hospital is being paid for, eventually you're going to have to conform, or they're going to make it very uncomfortable for you. You still can go out of your office and do whatever you want, but no hospital is going to allow any physician on their staff for very long through the recurrent liability in terms of cost or quality. There's quality pieces that come into this as well, but there's cost as well. So it doesn't take a genius to realize that hospitals are really expensive, and whatever you can do outside of the hospital is going to be cheaper than what you can do inside the hospital. So here come surgery centers, here come office practices where minor surgery is done, and a whole industry grows up of moving things that used to require hospital care into the outpatient realm. Cataract surgery when I was a medical student was a 2-day hospital stay. You came in the night before, had your surgery in the morning, stayed another day, and then went home. Cataract surgery, now you come in at 9 a.m, you're home for lunch. And you don't touch the hospital, you're nowhere near the hospital. All this minor orthopedic stuff, urology, plastics, ENT surgery, all used to be done in the hospital. Now it's done in surgery centers or in offices, which are much lower cost environments. So hospitals shrink. They don't have nearly as much business as they used to, and they shrink. The other thing, of course, is that doctors are costly. So if you can start getting people that aren't doctors to deliver medical care, that's a good idea too. So now we have a boom with PAs and nurse practitioners who, to a great extent, do almost the same work as physicians do in an ambulatory setting, but they charge less. They don't believe they need to be paid as much, and insurers won't pay them as much, or historically wouldn't pay them as much. So you have a favoring of PA and nurse practitioner practices, purely from a financial standpoint. So the pressure really comes on to move people through. Either don't admit them, or if they come in, they better leave again. There was a point where normal term vaginal deliveries were, the mother was expected to go home the same day. The baby, so the mothers went home without their babies because the babies got to stay 2 days. There was a huge backlash on this. The women called them drive-through deliveries. And now they've relented. I think you get a midnight. My recollection with my own children and my grandchildren is that their mom gets a midnight at least if she has a normal delivery and no problem. But they're also sending the babies home sooner as well. It used to be a week. Had a week in the hospital. If even C-sections go home in 2 days now. Then you start to see the beginning of this really funny terminology, which is the unnecessary ER visit, the non-emergent emergency visit. The cost of emergency care is very high because the place has to stay open, whether there's any big patients there or not. It has to be ready for a bus accident. And so you have to have very highly skilled people, very well-trained people, and all the stuff to take care of really sick people. But then the really sick people don't come that often. So you're sitting around seeing rashes and hemorrhoids and could I have a work excuse? And as a result, you still have to charge based on the overhead. So you have the $1,500 toothache, in the ER because the overhead is there, whether you're sick or not. So the payers who used to say, oh, if you go to the ER, it's an emergency, we'll obviously pay for this. They begin to really restrict coverage for emergency care. Generally now they'll pay if you're admitted. But if you come in and go out again, they're going to scrutinize that. And if they decide it wasn't an emergency, you're going to be stuck with either a big copay or no pay at all. So the idea that there are, if you will, discretionary emergencies begins to emerge in the 1990s. And that would be a good place to stop. Susan, do you have something to announce, or you just coming in to say hi? Nice, okay.
Military recruiter for us?
Yes, for you specifically.
For retirees.
I didn't hang out.
Where is this?
It's gonna be right here. So we're just gonna bring her in and get this. Sorry.